Assalamualaikum and good morning everyone. Thank you for attending the breakfast at UMHealth. And for this morning, we will have two sessions. One with the pediatric cardiologist that is with me, and as the moderator, and also from a talk on the eye. My job is to introduce the first speaker. That she'll be talking about, the title will be Percutaneous Congenital Intervention in Resource Limited Setting, strategic adaptation, leveraging available tool, training, and collaboration in order to maintain safety and efficacy in establishing percutaneous intervention in pediatric cardiology. Now, the congenital heart disease has remained the most common congenital malformation in the world, and in the recent years, we have seen remarkable improvements in treatment through percutaneous strategy, and but these innovations can be quite costly, especially in resource limited places like the Southeast Asia. So I'm going to introduce Dr. Noorintan Liana. Dr. Noorintan Liana has just completed her pediatric cardiology training at Sidra Medicine Doha, Qatar, in 2024, and also at National Heart Institute in 2023. And currently, she is working in the pediatric department. She is a very keen and passionate congenital interventional pediatric cardiologist, and she will be talking about this topic. So, to you, Intan.
Thank you, Prof. Imran, for a very kind introduction. Okay, so I'm Dr. Noorintan. I will present today about the congenital cardiac catheterization and the consideration in a resource-limited environment. Okay, as a background, the requirement of a cardiac cath procedure in pediatric and patient with a congenital heart disease might differ from adult coronary or adult structural intervention. Currently, there is no standard practice in the pediatric population, and usually the recommendation or the guideline varies among each centers across the globe. And my aim today aim to review on the best practice recommendation and how we're going to modify it and to adapt, especially in a resource limited environment, in order to provide a best quality of care to our group of patients. Okay, as we know, it's like similar to all other disease, a diagnostic and a treatment of congenital heart disease has also dramatically improved over the past 5 decades. And with the growth of interventional cardiology, the treatment of this group of patients has been remarkable. And traditionally, cardiac cath in a pediatric patient served before this as a diagnostic purpose, but nowadays all the diagnostic cath usually lead to the necessity of the interventional procedures. And as we know, then in Malaysia, the incidence of congenital heart disease is very high. It was estimated around 7 to 10 per 1,000 live birth. And it is among one of the commonest congenital heart defect. And among half of this group of patients are requiring surgery or intervention. And in the low middle income countries, most of this group of babies, usually 90% has still lack of access to the cardiac surgeon. And in fact, in Malaysia itself, one of out of 10 of this group of patients even died waiting for surgery because of the infection, of the complication of the disease. And the new development of the several transcatheter interventions and device has been designed as alternative to surgical repair or alternative to a stage before a definitive repair for this group of patients. And the advance in the technology, the profile of the catheter, the wire made it possible for even a complex intervention with a high success rate and a lower rate of the complication around the globe. So the persistent lack of access to a PITS cardiology, I mean, the cardiac surgery remained a burden to a global around the world in the patient with congenital heart disease. If we approximately see in the map, especially in the low middle and middle income country, a lack of cardiothoracic surgeon, especially expert in congenital, still remain an issue. Approximately a population, we need like a 4 in 10 million population, but in Malaysia itself, we are catering like 4 surgeon for 33 million populations. And in some continents like Africa or other remote area, they don't even have the surgeon. And the main challenge in Asia Pacific, especially in our region, in the congenital heart disease, we don't have a comprehensive cardiac care program because mainly of the human and material resources. And other challenges, actually, our populations is much dense and packed, and compared to the Western countries, and the cost of care also need to be considered, affordability, and not only availability of the surgeon, but availability of the device can be part of the limitation in the limited resource income countries. And not only that, the occurrence of the late presenters, they can have a high complication risk like elevated pulmonary vascular resistance added to the risk of the congenital intervention in this group of patients. And in the pediatric population, there are lack of a clinical trial as well. So causing a profound lack of evidence, and the document usually or the guideline usually rarely rely on the consensus of the international society expert opinion. And of course, short staff, reimbursement of physicians is also not achievable in resource limited and can also happen in the highly resource environment, but it shouldn't be prevent for all these aspiration. Until recently in 2024, expert consensus around the world, including the American, the European Association Group, Asia Pacific region, Australia and New Zealand, and also Latin America, has came out with the expert consensus about cardiac cath in pediatric patients and also involved in adult with congenital heart disease. And the best part of this consensus is included added accommodation to how we can adapt to a resource limited environment in this review. So, what is a definition of limited resource environment? The term previously was defined depends on the based on the country, low resource country, and low to middle income country defined based on their gross national income. But however, the definition might not appropriate or 100% correct, because in some middle income country that have a well-equipped cardiac center can perform a complex procedures, can also reside in the middle or low income country, and some high income country has a low resource lab. So the term of more correct to define is a high versus low resources lab, rather than low resources income. Can happen interchangeably. Okay, this consensus has made several recommendations to ideal cath lab management, include the ideal team members. Usually, the ideal team members consist of a physician leadership or non-physician leadership. Physician leadership, like Prof. Imran, as directors of the cath lab, responsible for mentoring, training, maintaining a standard practice, developing a protocol, implement the policies, while a non-physician leadership, for example, in a cath lab manager, the responsible can be overlapped with the directors of the cath lab, but they mainly focusing on the nursing and technical staff, and he or she might be responsible for the inventory management. And other responsibility like cath lab staff, scrub assistants, circulator nurses, recorded cardiovascular technician, and sometimes need more than two operators in the complex congenital cases. What happened in the resource limited? So in the resource limited, one rule can have multiple role in one of the leadership or staff. For example, cath lab manager can also act as a recorder technician at the same setting, and also a limited assistance for the operator is part of the challenges in the limited resources. So, how about the cath lab suits? What is the recommendation? Ideally, the cath lab size is still highly variable compared to adult coronary intervention. 700 to 800 square feet can be relatively small for pediatric. Ideally, the room should be like a size of 1,000 square feet, because it should provide a more flexibility when conducting especially complex procedures, and the space for other team members, for example, the position of the echo machine, the C-arm fluoroscopy, the monitor, sterile table. And in many countries or centers in pediatric or congenital intervention, anesthesiology are needed during the procedure. There's adequate space for anesthesiology, the machines, equipment, wall oxygen is also needed to give access during the procedures. And the consumable and supply, ideally, the stock keeping consumable also needed in a wide range because of wide range of the pediatric sizing, and also the different type of the procedure are needed to accommodate this group of patient, and the storage as well. But most importantly, some bailout equipment must be available during emergency. For example, covered stand, snaring in a coil device. If the complication happen like a chest drain, a pericardial drain should be readily available. So what happened in the resource limited environment? In resource limited, to establish a pediatric and congenital cardiac cath is extremely an expensive area within the hospital. So some we need to share the equipment to other specialty. For example, adult cardiology team, the vascular team, or interventional radiology, as well as sharing the consumable item with the adult coronary cases. And the operator might also need to utilize a single plane. Ideally, we need a biplane, but because of the limited technology, sometimes we just use a single plane to this. And a strategy actually need to meet the demand, and it often require a flexibility of the operator to adapt the equipment, to adapt the catheter, to adapt the environment as much as possible. And because of this, sometimes procedure might be taking a longer time, and the procedure success and outcome can be affected by this limitation. And to maintain a large stock consumable is also impossible at the start of service, especially in the resource limited environment. Hence, the operator probably need to review ahead of the equipment needed. For example, I did in the patient with a PDA device. I lay out the equipment needed to purchase first beforehand. But however, the challenging for this is dealing with complication can be challenging and limitation because of the limited availability of the other sort of device. Okay, then we will discuss about what is the ideal type of facilities for congenital cath lab. Ideally, still pediatric congenital cath lab cannot function in isolation, so it's require other cardiac services, support service, organization arrangement, support from the administrators to provide optimal care. Around the globe, around the world, there are a variety of facilities available. It's either a children hospital with adult facilities, or a children hospital adjacent to adult facilities, or a children's service within the adult facilities, or a freestanding children hospital separated from adult facilities, or a freestanding national like a cardiac hospital in our National Heart Institute. So there are pro and cons, advantage on challenges. So if I take consideration to our local setting, we are a children's service within the adult facilities. We have a pediatric subspecialty support available and proximity to maternal units and delivery service. But the challenges is mainly combination with the adult service, often like leadership domination or resources might need to be focused more towards the adult and compared to the need of the pediatric and the location for patients for pediatric might not be spreading out throughout the facilities of pediatric patients. And before I talk about the backup of surgery and ECMO backup, I will talk about the risk on complication. Life-threatening adverse event in overall congenital cardiac case is around 2%. And just among these 2%, the survival of this group of patients usually depends on the availability of surgical or circulatory backup. How we calculate the risk is depend on the case, the hemodynamic status, the type of procedures, and also the diagnosis of the patient. There are many available tools online and also scoring system that used to score and to calculate the risk, and we can give to the parents during consent as well. In 2015, there are CRIP scores developed by the congenital cardiac interventional studies, and in 2022 added on the new contemporary new I mean technology or device or procedures to predict scoring and risk category and serious adverse event. So adverse event is defined as whether it is an anticipated or unanticipated event which could harm the patient or not. So the data frequency on urgent ECMO or surgery is still scarce and limited to single institution. We have like a 5 level of adverse event. Usually level 4 or 5 is the one between the 2% of the serious adverse event that major life-threatening requiring probably cardiopulmonary resuscitation or urgent emergency surgical intervention. The adverse event can be due to the vascular trauma or technical reason like device or stent migration, and usually traumatic to the vessel or cardiac itself, risk of a high risk of need for this ECMO and surgery and even mortality. So, um, surgical backup or circulatory ECMO. Surgical backup focus on the requirement of surgical repair in order there is a trauma happen or during the device retrieval. So the ECMO in this purpose is requiring hemodynamic or oxygenation support. There are multiple category of backup according to the potential urgency. We call it surgical standby or circulatory support, ECMO standby, when there is surgical team standby within the cath lab itself and can have surgical support immediately, while ECMO within 10 minutes activation. Rescue surgical backup or rescue ECMO within 15 minutes of surgical backup available, or 30 minutes to 1 hour of ECMO. Deferred surgical backup or surgical ECMO support is established ECMO within at least 3 hours. Surgeon can be off campus, scrub somewhere else, but within available within 1 hour, or no backup at all. So as we know that surgical backup is important, potentially life-saving, and expert consensus also recommend that certain therapeutic procedures need a surgical backup facilities. But in recent, ideally, the rescue backup is needed for all the procedures, but acceptable nowadays in some of the diagnostic procedures without backup, like coronary angiogram and standard septostomy, a non-critical balloon valvuloplasty for aortic or pulmonary valve, or and other things is needed as surgical backup. However, in some patient like weight of patient less than 1.5 kilos, for example, in a prime baby, they did the PDA intervention. Surgical backup might not even be feasible. Even this is a life-threatening condition if complication happened, because there is no ECMO cannula or surgeon can operate still in this group of patient. And some surgical availability in very remote area where a salvage procedure is needed is also not suitable for surgical intervention. Obviously, understanding and discussion with the parents is very important when requiring in this situation. How about ECMO backup? Recent advance stated that established ECMO program is not necessarily a requirement unless if the surgeon can still do like a circulatory support using a cardiopulmonary bypass is still okay if we can proceed with the procedures. For example, no backup in the salvage procedures. Again, in a patient with less than 1.5 kilos is also no backup for ECMO. Whether the high-risk case was identified, it should be like a multidisciplinary discussion and all the relevant critical care, anesthesia, and also intensivists includes the cardiology team as well. So, surgical and ECMO backup become more complicated, especially in the resource-limited environment with our lack of surgeon availability, and with the country sometimes without surgical expertise. And so the case selection is very important with low serious adverse event. And meticulous selection criteria, and what is the most importantly is the informed consent to include the full disclosure about the procedure that will be performed without the surgical backup if the patient develop this serious adverse event. And then interventional operator experience so needed of mentoring is also important in reducing a serious adverse event. And the availability of resuscitation equipment and ICU backup is also very important. So how about anesthesia and sedation? Existing recommendations is depends on the procedure risk and also the condition type of patient, whether it's neonates, infant, behavioral limitation, deep sedation or GA. And some center in adult population with congenital heart, they can use the local anesthesia to mild to moderate. But in the high risk as expected of the high serious adverse event, general anesthesia is anticipated. And this is the example of a higher risk condition. Okay, so but some center did operator manage sedation, especially operator that knows about additional ICU background, has experience in side effect of sedation, knows how to manage airway, and has a backup ICU emergency trolley and supporting nurses to monitor the patient. However, the operator managed sedation become less popular, and because the operator can also need to concentrate on the procedure while need to worry about the anesthesia or sedation. So when the anesthesia is involved with interventionist, open communication is very important. Um, the hemodynamic changes, whether the anesthesia give oxygen supplementation, ventilation mode, volume infusion during the procedure is very important as it can change the hemodynamic of the patient, the rhythm, the medication, the position of the C-arm, fluoroscopy, and the position of the GA machine. And we have to expected complication should be communicate with the anesthesia. So the key here is the team huddling before the procedure started to adequately gather all the information, expected complication, and also to improve in the successful of the intervention. So again, the pre-procedure planning is very important. Need to limitation like human resources, dedicated nurses for anesthesia, for the cardiology is need to be arranged earlier. And a detailed discussion with the family, not only for the complication but the cost of the device. Sometimes the cost of the surgery can be more affordable, so the cost should be discussed with the family member. All this planning, improved communication has substantially improve patient safety, whether it is a highly resource environment or low resource environment. So it costs a very little, and but it can improve the patient outcome. I will talk about adult congenital heart disease. As overall, because of the cardiac care continue to improve, most of our patient has grew to adulthood, and it is another challenging area, even in the resource limited and or other part of the world. In some center, adult congenital intervention still being performed by a non-congenital cardiologist, but there are still lack of clarity who is the best interventionist to perform in this patient. Until clear training requirement are established, the expert to those who can perform this center is remain heterogeneous. So the younger generation of the congenital interventionist should set the framework of their care. This is the example of the ASD device closure we do here in the adult population. And then this is in another center we did post previous tetralogy of valve repair. So we did a percutaneous pulmonary valve implantation in a 40 years old man. So the first year of interventionist career served to continue time to train, and with this rapid development of the new procedure, new device, the networking and mentorship is very important for early career. As this complexity of the cases continue to evolve, the clinical networking becoming more important whether to national or international level. So again, the partnering with local expertise, for example, us in National Heart Institute and Pusat Jantung Serdang is also very important. Government agencies, new international organization. This is especially in establishing a new organization is very complex and require ongoing support and funding, and significant also resources need to be established in the organization. This is the proposed protocol. I mean the how they can improve in the congenital cardiac care, alignment with local government, endorsement with the professional societies, collaboration with the others, hospital, university, public, private, and NGOs, focus on the multidisciplinary team, and engagement with the parents and the communities. The other challenges is funding. Is the most significant challenge. Absolute burden towards the family, impact on the health, economic consequence, and poor private insurance coverage is also one of the major challenge. So funding can be taken from the charitable foundation, but it's really hard to sustain. So you need a government step through a population-based program, need advocacy, coordinated effort, and a substantial political will. The other thing is train the trainer is common in high income country where they trained to improve in the care provider, and also they has approach to a low middle income country where in some regional like screening congenital heart disease in Abu Dhabi, building a pediatric cardiac care in Georgia. Organization like Children Heartling has also came to Serdang and IJN to develop a center of excellence in our region. So I just summarize one of the literatures that examine a multi-center data in a lower middle income country. They did among 1,973 cases where low risk patient more than 1 year old, and the device closure of ASD and PDA is usually performed. The serious adverse event is 2.8%. The mortality is 1%, and it's still comparable to the US registry. Risk factor for serious event include low weight, low oxygen saturation at baseline, and other cardiac comorbidity. And the mortality is highest in pulmonary valve perforation and PDA stenting because of failure to rescue because no ECMO availability or surgical bailout during the procedures. But the conclusion from these literatures, they conclude that congenital cath can still be safely performed, and to adapt knowledge transfer to webinar discussion, report, mentorship has been associated improvement in mortality and morbidity in this group of patients. So I will share about our experience from 2025. We have 9 patients, one underwent diagnostic cath, 4 PDA device closure, 3 PDA-ASD, and 1 BSD. Complications, one developed atrial fibrillation in adult ASD, only requiring medical treatment, and one had a migrated PDA device requiring surgical retrieval. This one has done to the other center. So again, the principle of good governance is also important. A clear vision and mission, decision-making, leadership, accountability, and learning from failures, effective collaboration, and also performance orientation. So I come into a conclusion. Irrespective of the resources locally available, we should strive to improve the quality of care provided to our patient. Establish the standard cath lab in congenital heart disease is also important, and it requires a multidisciplinary additional core cardiac service and support group to provide efficient care for this group of patients. Thank you. Any questions?
Uh, th- Thank you, Intan. I think we are already out of time. We have eating onto the ophthalmologist time. So anyway, just to summarize the talk, uh, you know how important it is in a congenital intervention like this. And for many years, we have been struggling in PPUM to have an effective and sustained pediatric congenital intervention. And with Intan returning back to PPUM with her training, it proves a valuable resource for us to develop and advance further. We are in the interventional lab. We are happy to have Intan around because and we will give our full support for the development of this area. So thank you, Intan. If there are any questions, you can contact Intan via email or contact her directly. So I think it's time for me to pass the baton to Prof. Sujaya for the next talk.